Hi, you guys. Welcome to Ask the Egg Whisperer. I'm so excited to be here tonight. This is a bonus session. I looked at the log or the backlog of questions that I have, and I literally have 200 questions that you guys have sent in, and I want to answer every single one of them, and I promise you it is not going to be tonight. So don't worry. I know you guys know I could totally sit here and answer 200 questions, and I would love to do it, but I'm going to answer, I think, about 10 or 12 tonight. So thank you guys for tuning in. Thank you for sparkling and being there and wanting to bring more love into this world and doing everything you are doing to do that. So I'm going to start off with a question. So let's do this. I have Julia, and Julia is saying, Dr. Amy, you're so supportive and informative, and I love your sense of humor. So Julia, have you been walking around asking everyone what they think of the erection? And have they been watching the erections? If you guys don't know what I'm talking about, watch last night's Ask the Egg Whisperer, and you're going to get what I'm talking about. So someone asked me, she said, one of my best friends, she said to me, is your mom mad that you talk about her like that and said that she does that? I'm like, no, she can't hear me anymore. She would think I'm saying election. Okay. This is from Julia. I'm 44 years old. I was previously on estradiol, prometrium, and DHEA for early menopause symptoms. I was told it was a slim chance to conceive, and I understand that due to my age, it sucks. I know. Otherwise, I'm healthy. I had my levels checked at 2 different clinics, and they were totally different. First time it was FSH of 31, estradiol 73, AMH of 0.1. 4 months later, FSH of 9.5, estradiol of 465, AMH of 1.2. So our question is, how come the levels changed that much? Should I get them tested again? I'm now starting the IVF process. My doctor is not very hopeful. I started androgel and birth control pills this week. I'm very worried that the fertility pills about the pills due to my age and low AMH. Should I be taking it? I'm feeling lost. Should I at least try? Okay, Julia, this is the thing. Based on your AMH level of 0.1 and your FSH of 30, it sounds like you'd probably have 1 or no eggs to retrieve, right? Doesn't that sound cruel? That's the reality. Let's talk about things and still have lots of hope. You guys all know what I mean when I say hope. Have only practical and pragmatic and positive expectations, okay? So if a guy showed up and he said, I really want to try with my 1 sperm cell, we would be like, oh, dude, I'll do whatever it takes. But for women, we're just like, like, meh, all the noises I'm making, because that's kind of like how we feel when doctors talk to us like that. And I'm 44 and you're 44, and I totally get like what you're thinking and how you're thinking, because most of my patients are also over 40 and they share the experiences that they have with other providers as well. But I understand why they say the things that they say, and but sometimes I feel like it's important to talk to patients in a more loving way, and not that they're not loving, but you know what I mean. So let me just tell you what I'm trying to say. Look, Julia, try, because if you don't, you might look back and say, I wish I had tried. And I would regroup with your doctor and say, like, why are you giving me birth control pills and testosterone? My AMH is 0.1. The likelihood of me getting more than 1 egg to grow is pretty low. So why not just consider a natural cycle IVF or a mini IVF cycle and not do all this suppression and priming with testosterone? However, your doctor might say, this is the reason. It's because I saw so many follicles on your ovaries and I got super excited, and I think that I have a special sauce here that I think would work for you. So ask those questions up front. To answer your question about the AMH going from 0.1 to 1.2, the answer is it doesn't do that. It's impossible, literally. So I'm thinking that it was a lab variation, or someone just emailed you a result and didn't give you the official report. So be sure to get the official report. And if you aren't taking NAD or pterostilbene or CoQ10 and a really good prenatal, do so and just look at everything. Be sure to look at the sperm. And I would say go into it with a low expectation. We're talking about a less than 5% chance of IVF working with the numbers you've shared with me, but it's certainly not 0, but have a plan B. And when I tell people from Jana Rupnow that I learned, I love this quote, plan B is sometimes the plan that was meant to be, or it actually is the plan that was meant to be. It's sometimes we think of plan B as bad, but I don't necessarily think of it that way. Okay, this question is from Anna, and Anna is saying, what are some questions to ask a doctor when looking to start IVF? Anna, I'm so glad you asked this question. Here we go. What is my diagnosis? Why are you choosing this IVF protocol for me? What will my IVF pyramid look like? How am I going to approach a transfer in my situation? Or how are you going to approach a transfer in my situation? What are my IVF options and what is best for me? Whether I should do a fresh transfer, frozen transfer, with or without genetic testing? And what is the best advice you have for me given my situation as to what I should do to best prepare for transfer? What's up? That's how you do it. I should have a jingle that goes with that, maybe a song. Okay, this question is from Jenna. Jenna is saying, hi, hi, Dr. Hi, Nicole. It's great to see you on here. I love it when you say hi. This question is from Mariana. Okay, so Mariana, oh, actually, I lied. I skipped one. This is from Jenna. Okay, guys, I swear, this is Jenna. Jenna's question is, hi, Dr. Amy. Do you think using Menopur produces better quality embryos than using low-dose HCG? I'm hearing conflicting things, but I was prescribed low-dose HCG. Help. Okay, Jenna, here's the dealio. Some doctors are using low HCG because that's what they've been using forever. And in their hands, they have really beautiful embryos as a result of it. But what you might not know is there is a nationwide shortage of Menopur right now in this country, and doctors are being super creative. See, I got a guy that gives me Menopur, and even there's a shortage, I got some. I'm kidding, but not kidding. So there are different ways to work around the Menopur shortage, and one of the ways is low-dose HCG. It's been around forever. Before Menopur, there was low-dose HCG. So whenever I have a patient that says, my doctor wants to use low-dose HCG, and they've been using it forever, I'm like, your doctor's probably over the age of 60, not that there's anything wrong with that, and they feel really comfortable using low-dose HCG because that's what they've been doing, and there's nothing wrong with that. In my personal opinion is that low-dose HCG is a great substitute. If your doctor feels that it's going to give you gorgeous embryos, go do it. If it's going to make your eggs sparkle and they really feel strongly about it, trust them. Because if you dose it right, it can work as well. So this next question is from Mariana. She says, hi, Dr. Amy, my transfer is in 2 days. I like to take showers to relax. I do too, actually. I will take one before the transfer. That's really good. And I want to know whether I could take another one after the transfer. The day of the transfer, is it better not to? Thank you so much. Okay, Mariana. Butt to bed, butt to chair, butt to couch, butt to toilet, butt in the shower, and rotate. That's what I tell my patients. Not necessarily the butt in the shower, but I tell people, look, after a transfer, you can take care of your activities of daily living. It's not like you're going to be in a straitjacket. I want you to not lift a finger and open your mouth just for the peeled grapes to be dropped in by your cabana boy. So you can shower. You can take a relaxing shower. I want you to do things that you enjoy. The thing is, we have no control over whether an embryo is going to stick and grow, like zero. I mean, we can control the things that we can do to prepare to get the embryo in, but once that embryo is in, there's nothing that we can really do. We had a doctor on, Dr. Provost, she's hilarious, and she said, I tell patients they can do whatever they want as long as they're not riding a mechanical bull. That's funny, right? Riding a mechanical bull after a transfer, like who would do that? But I've actually had patients ask me if they can go horseback riding. So I can now just tell people you can't go horseback riding or ride a mechanical bull after your transfer for a while. So please trust me with that. But long story longer, back to my control story. When a transfer doesn't work, the first thing we do is beat ourselves up, literally. Like I have patients that say things like, I think I walked up 3 stairs and that's why this transfer didn't work. And I'm like, believe me, trust me, I promise you that is not why your transfer didn't work. It has nothing to do with why your transfer didn't work. The answer is in the cells, and we can't look at the cells because that's just not possible, unfortunately. Okay, this question is from Nancy, and Nancy is saying, hi, I'm 39 years old. My day 2 labs are FSH of 7, estradiol 46, AMH of 4, no prior pregnancies, no issues except for my age. My husband has male factor infertility with a low motility, low but okay morphology, and mild varicoceles. We underwent IVF with ICSI, had 18 eggs, eventually 9 blasts. Holy smokes, that's really good. Preconception genetic workup, done, all normal. After PGTA, we ended up with 1 normal embryo, the rest were abnormal. What can we do in prepping for round 2? I'm on CoQ10 prenatals, fish oil, vitamin D. Should we consider DFI for him first? Thanks so much, love your work. Okay, Nancy. Yes, let's do the balls method. It sounds like you've done it. Let's look at the background genetics that looks at the sperm DNA fragmentation test. It sounds like you already know that he has varicoceles, and maybe consider, if the DNA fragmentation is really high, removing the varicoceles if it's a grade 2 or grade 3, if it's something that's clinically palpable. Consider using Pixie or Zymot as well, in addition to ICSI that you're doing. Look at his lifestyle, look at his labs, see if his testosterone's low, look at other levels like prolactin, thyroid, and then talk about sex. I just felt like saying that, right? Isn't that fun? Just talk about sex. I told someone today to be intimate, and they said, what did that mean? You guys, that's cute. I want it to be like, you snuggle, you spoon. But in my office, it's talking about sex. One day, Salt and Peppa will invite me on stage, and we'll sing, let's talk about sex. I can dream. I told my husband for my 50th birthday, that's what I wanted. I want Salt and Peppa. Honey, are you watching? I want Salt and Peppa at my birthday so I can go on stage and sing with them, because I got lots of tunes, that I could like build in to their songs for my patients that you guys would love. Okay. This next question is from Jess. Jess is saying, "Hi, Dr. Amy. I've had my baseline scan. It was fine, but my period is now 10 days late. Why? I've taken a pregnancy test, negative. Have I scared my period away worrying about starting IVF? How can I get my period to come? It's always so regular and I'm really frustrated. I want to get started. Please help." Okay, Jess, if you were my patient, you come in for your baseline and your period hadn't started yet, guess what I'm going to do? I'm going to check some levels, right? Estradiol, progesterone, FSH, sometimes HCG. So let's see what's going on with your body. Your levels will tell us what is happening. So it's now been how long? Like 10 days? Holy smokes. Get your levels checked again. Go back into the doctor, get your levels checked, take a look, see if there's a cyst, and figure out what's going on so you can have a plan. Wondering what's going on is really frustrating. It can cause a lot of anxiety, and there's absolutely no reason for you to sit at home and wonder when you can just march on in, get a little cyst check, say hi to Wanda. For me, it's my karaoke machine. It really is. When everyone leaves the office, I play tunes on my ultrasound machine. I had Samsung make me a special machine that actually runs music. Okay, this question is from Kimberly. Kimberly says, "I am torn. I've had 2 miscarriages trying for baby number 2. And Kimberly, I'm sorry. One was a chemical pregnancy or a biochemical, and one miscarried at 5 weeks. I'm 38 with an AMH of 0.5, so time is also not on my side. I've had a previous myomectomy and C-section. I asked my doc to check for everything, and she agreed to do a hysteroscopy, endometrial biopsy, even though she thinks it's not likely causing what's going on." Okay, Kimberly. So it seems like we know your diagnosis. You're 38 years old with a low AMH. We know that women who have an AMH less than 0.6 are at higher risk of having a miscarriage. I'm glad to hear you've had a C-section. That's really helpful for me in terms of guiding us as far as what's going on. So I'm thinking, check the fallopian tubes, make sure that the biochemical, isn't from, let's say, a hydrosalpinx. I would ask your doctor if in your history there's some reason for them to do some sort of autoimmune testing. I would look at the sperm DNA fragmentation and see what's going on there and get you guys on supplements like CoQ10. And then I always tell, my Egg Whisperer golden rule, if you're 37 years old and you want one more baby, even if you already have one at home, I suggest going right to IVF. I don't want to take your precious eggs for granted. You have them. Your AMH is 0.5. So start talking to your doctor about moving forward with IVF now. You've been through too much already with the biochemical and the miscarriage. And see if your doctor recommends IVF with PGTA and an FET. And maybe consider more genetic testing like a carrier screen and a chromosome analysis too. So those are the kinds of things that I would talk to someone about who was 38 years old with an AMH of 0.5, who already has one baby at home and now has recently had a biochemical pregnancy loss and a miscarriage. So I'm really hopeful for you. There's still hope. There's still a really good chance that you can have another baby with your own eggs. So don't give up, keep showing up, and hopefully you guys will reach your goals of having one more baby as well. Okay, next question is, so Kimberly asked more questions, you guys. It's on page 2. Here we go. People in my Facebook group have said these tests, like a hysteroscopy and endometrial biopsy, are very painful. I'm wondering if I should cancel them. What would you tell me if I were your patient? Okay, so what I would say is a really nice cavity evaluation is super important. So that's why I mentioned the HSG. The hysterosalpingogram is horrible. It's the most barbaric test. You're walking into a cold room half naked. Someone you've never met before who probably rarely sees a vagina walks in with this big metal thing in your vagina and puts it in there and starts mumbling, and you're like, what? And they can barely get a catheter into your cervix and they're pushing this dye in and you're like, holy smokes, if someone could warn me about that first, thank you very much. And then it's done. So that's the thing. Go in prepared. I offer all my patients a Valium and a Tylenol with codeine 30 minutes before. We give them instructions. They take a doxycycline, which is an antibiotic, the night before and the morning of. And I get the images in real time. Basically, you have it done. I can see it on my computer. So that's a beautiful thing, right? I get to tell you to stop your antibiotics if your tubes are open, to continue your antibiotics if something is wrong or the tube is closed. And then we communicate in real time. So if you're someone who is very uncomfortable with speculum exams, you have some low-level anxiety around medical procedures, there's no reason why you should worry and be scared of doing stuff like this. That's why a little Valium can sometimes go a long way. You're not going to become addicted to it. It's just one tablet 30 minutes before. Same thing with the Tylenol with codeine. So we wouldn't put an animal through a procedure like that. We wouldn't take a catheter and watch an animal suffer in a vet clinic. Why do we do that to women? Maybe Dr. Amy for Surgeon General. Hi, there should be a fertility Surgeon General, you guys, don't you think? Yeah? Okay. So this question is from Heather. So Heather says, I'm preparing for an FET, cycle 3. We are transferring 2 untested embryos. They weren't strong enough to be tested. I'm 37. No success ever. This is our last round. And we tested NK cells, which came back positive high. I know many friends with similar NK results. And they infused the entire 100-liter bag, but my dog has me only... My dog. See, I was talking about dogs a second ago. You guys just didn't know. My doctor has me only doing 4 mLs. I worry it's such a small amount and won't be enough. My cells are only slightly elevated at 12. Any thoughts if this will be effective given the low dose compared to what others with similar results have had? Thank you. So, Heather, this is a great question to ask your doctor, and I would do this. I would say to your doctor, I would love to see some literature that you're basing this recommendation on for me. Why are you giving me such a low dose of intralipids? It makes sense to me just to make me feel better. I just want a standard dose. See, wasn't that easy? And then if they still say no, I would say, it's okay. Go to Jamba Juice and get a protein shake and drink it. You can sit there for 2 hours and be like, oh, this is so much better than being tied down to a chair for 2 hours. But that's the reality. I don't really know. It sounds like we know your diagnosis. It's embryo progression and embryo quality. So I don't think that the natural killer cell level is affecting that. And I don't think the intralipid fusion is necessarily going to make a big difference. But I think it's so important for you to feel heard, for you to feel like you're getting the treatment that you need. And when all your friends are doing something, certainly I want you to get the same level of care. So maybe suggest that you're just going to feel better getting a better dose. Because honestly, like getting a higher dose isn't going to hurt you. And I don't know if they're really just giving you 4 milliliters, if that's really worth your time and effort. Okay, next question, guys. This is from Saki. Hi, Dr. Amy. Thank you for answering our questions every week. I'm sure it helps a lot of people, and I love how funny you are. Someone thinks I'm funny, you guys. I'm 31 and was diagnosed with unexplained infertility. We've been trying to conceive for about 2 years. You guys, unexplained, eye roll, right? I tried 3 cycles of Clomid and 2 cycles of letrozole, but no luck. My doctor told me my progesterone was low, but after taking Clomid, it went up to normal range. So I'm wondering what it is that's preventing me from getting pregnant. My tubes are open and we took genetic tests and there was no problem. Currently, I'm taking Chinese herbs for 4 months. My basal body temperature was very stable on the first 2 cycles, but the last in this cycle, my basal body temperatures are just all over the place. My Chinese medicine doctor suspects that I might have endometriosis. If I do you think I'm wasting my time doing Chinese herbs? I'm planning on doing IVF early next year if this doesn't work. Okay, Saki, your medicine doctor might be onto something. So endometriosis, especially silent endometriosis, is extremely common. Like so common. Some people say sometimes as many as like 70% of women with infertility have silent endometriosis or at least some form of endometriosis, including silent endometriosis. So dig deep, think about your symptoms. Do you have pelvic pain? Does it hurt when you have your periods? Does it hurt other times? Do you have problems with, for example, pain with intercourse? Has anyone really looked really closely at your ovaries to look at the tiny follicles and maybe to see if there's any endometriosis there? Is there something with the tilt of your uterus that perhaps could suggest that you might have some endometriosis? So I don't think it's a bad idea to look into it. Obviously, with 5 cycles of letrozole or ovulation induction, being 31 years old, I'll tell you what I'm thinking. Number 1, repeat your FSH, estradiol, and AMH. We can't rule out that this could be a fertilization issue that's basically egg-driven. Really look closely at the sperm quality one more time. Look at the morphology and don't let them sugarcoat the sperm. Don't let them be like, it's so good. There's not that much, but it's okay. That frustrates the heck out of me. Consider doing more advanced sperm testing like a DNA fragmentation test. Sometimes that can reveal stuff that will help you better prepare for your IVF cycle and choose the right IVF option when you're ready to do IVF. Sometimes I see things that kind of drive me a little nutty. One of them is you've gone through all these IUI cycles or ovulation induction cycles, and then what happens is they do IVF and they don't do ICSI. And then they're like, well, we just thought if it didn't work next time we would do ICSI. I mean, right? Didn't I just say, right? That the egg quality could be an issue, but also fertilization could be an issue because of something with the sperm. So be sure to consider ICSI with your IVF cycle. And then you can always test for endometriosis after you've created embryos. So you can do a frozen embryo transfer, you can do the Receptiva DX test, see what the results show, and then go from there and not feel like you're missing anything. And if you haven't done an HSG in the last year, for example, if it was over a year ago, look at it again, consider doing it, and maybe even take the images, take it to your doctor and have them look at it too. That's what I do. I mean, that's what I love about doing the HSG at a center that I have the ability to get the images for or images from, so that I can actually look at the images and be like, yes, that's the right read, that's not the right read. And I've actually called the radiologist before and said, you missed that. And they're like, oh yeah, sorry, you're right, I'll redo the report. So unless you're actually seeing the official reports, remember I'm constantly saying, have you seen your official reports? Then you'll know what's wrong. And I don't want you to miss anything, because after going through a couple of years of what you've been going through, it gets pretty tiring even after like 1 or 2 tries, let alone, 24 tries. Okay, thank you, Saki, for that question. Okay, this is from Elise. And Elise is saying, I'm trying to conceive and tracking my cycles after a miscarriage. Do you have any tips? Must we wait for HCG to go back to normal before the cycle restarts? Or can you ovulate and conceive with HCG in my system? Will your HCG then start going up again? Internet doesn't really give you a straightforward answer, so would love to hear your comments. Yes, Elise, I am faster than any Google search. It is true. So this is what I tell my patients. If you feel like trying right after a miscarriage, you can absolutely try. Typically, you'll start ovulating about 4 to 6 weeks after the pregnancy has left the uterus. That ovulation could be your next golden egg. However, sometimes there's a little bit tissue remaining inside the uterus. That's why the first period after a miscarriage can be sometimes wonky. That's the term I use. People are like, this period just feels weird. I'm like, wonky. See what I mean? Sometimes it can take 1 or 2 periods for you to kind of get your uterus to do, or to get your periods to feel like they felt before the miscarriage. So I tell my patients, especially because my patients are over a certain age, and they're usually over the age of 37 on average, if not closer to 39 to 42 most weeks. I tell my patients, I don't want you to miss out on an opportunity on trying, so it's not dangerous to try. However, we talk about the 3 questions. What do you want? What is it going to take to get to what you want? And are you willing to do it? So if you're in a situation where you've had a miscarriage and you don't know your AMH level already, find out what your AMH is. See if it makes sense for you to do something to preserve your fertility now for the future. Because if, let's say, you find out that maybe your AMH was low, or you find out that you have a chromosome issue, it might make sense to do something in advance of getting pregnant naturally. But getting pregnant naturally isn't dangerous. It isn't bad. It's just another chance for a healthy pregnancy. And we just know that every pregnancy we never take for granted, because things just sometimes happen that are completely out of our control. And I have that method for those of you who haven't heard of it before. It's called the Angel Method or Angel Approach. I feel like anyone who's ever had a miscarriage who's going to try again for another baby, you should know everything in this method and ask their doctor if it's something for them. So the A looks at your age, your AMH level, and any possibility that you should need an autoimmune workup. N is looking at your nutrition, your body size, what you're eating, the supplements you're taking. G is looking at genetics, making sure you're doing enough genetic testing. Chromosome analysis, carrier screen, for example. And then the E is endocrine abnormalities and ruling them out, like a thyroid disorder, diabetes. And then the L is looking at your lifestyle, looking at medications you're taking, medications your partner's taking if you're in a heterosexual relationship. Okay, guys, that's the Angel Method. So this next question is from Carla. Carla's saying, hi, Dr. Amy, I'm 36 years old. I've been trying to conceive for 4 years. I've gotten pregnant twice on my own. One resulted in a miscarriage at 9 weeks, and one was a biochemical pregnancy. I started my first IVF cycle, and I had my egg retrieval. I have 6 PGS normal embryos. That is awesome, Carla. Congrats. That must feel really good. I'm getting ready for my mock cycle. My doctor and I discussed an empiric autoimmune protocol for my transfer, which includes intralipid infusion, Lovenox, and steroid use. Do you recommend this protocol due to my history of miscarriages? Will this protocol affect me negatively? Okay, this is my thing. Test, don't guess. I learned that from someone pretty awesome who taught me that little mnemonic, right? So I don't know if it's a mnemonic. You know what I'm saying, a little saying, a little mantra. Test, don't guess. So the thing is, if you actually carry something that requires you to take Lovenox, sometimes you would want to know that before a pregnancy, because you might need the Lovenox even like 3 months postpartum to prevent whatever the badness is that potentially could have been linked to the 2 miscarriages. The other thing is, rule out a uterine anomaly. Make sure you've looked very carefully at the cavity of the uterus. So one thing I do when I do my mock cycle is repeat a saline sonogram if it hasn't been done in the last year, or an HSG hasn't been done. Sometimes I repeat it even after, if it's been 6 months, and maybe even do a hysteroscopy. So taking a camera in and looking at the uterus very carefully. And you can do it on the same day as the biopsy. That's what I do for my patients. They're not going through more than they already have been going through. So intralipids, I don't necessarily use that empirically. I do it upon patient request for patients who just feel like it's something that they want to do. I wouldn't say no, but I just explain, why it may or may not work for them. Lovenox is something I do empirically. If someone has had not 2 transfers, but someone who is in your situation with 2 miscarriages, and let's say I do the workup and there's no thrombophilia, there's no antiphospholipid antibody syndrome, I would actually still offer the patient Lovenox as a novel way to address autoimmune issues. And then lastly, steroid use. I do give patients steroids 4 days before their transfer. Not everyone can tolerate them. Not everyone takes them. Research shows it may or may not help. It's hard to say, but maybe in a case like yours, it's something to consider. But I wouldn't feel too strongly about it. If it's something that you want to decline it. Chances are everything will still be just fine. So good job doing everything that you're doing. You're definitely marching along the Egg Whisperer diet, which is what I'd like to think is the recipe that gives patients the highest IVF success, knowing your diagnosis, doing your IVF cycle, addressing the diagnosis, doing your endometrial testing, which is what you're doing with your mock cycle, and then transferring. So good job with all of that. You guys, thank you for being here. I love talking to you guys. I'm getting a lot of live chatted questions, so I'm going to go through that. And you're probably wondering, sitting here, I wonder if there's a way I could be in a class with Dr. Amy for 1 hour with just a handful of people. The answer is yes, you can. So I have something called the Egg Whisperer School, and my next IVF class is on Monday. So do join. It's super fun. I crack way more jokes than what I'm cracking here, and I have fun doing it. So I hope you guys will join me. So I'm going to go to the first chatted question here. It is going to come here. Let's see. Here we go. What are some of the reasons to get no embryos after a round of IVF? I'm 33 years old, AMH of 3.7, had 25 eggs retrieved, 10 mature, fertilized, but none made it to day 5. I'm heartbroken and confused. Amanda, I'm really sorry. That is heartbreaking. It's confusing. It's frustrating. It's soul-sucking. It's energy depleting. It's like, I could go on. And each case, for me, for my patients, feels like my own. So when something that happens, it hurts so deeply. So I can only imagine how that makes you feel. Especially when you're 33, you're young. Like, that shouldn't happen. You know what I mean? It's like, why did that happen to you? And I can totally see why your head is just reeling, and it's just so hard to wrap our heads around this. So what I would ask the IVF doctor is, I would say, I'm so glad I have this information now. I now know, why things haven't worked until now. And I have the most information about my fertility diagnosis, because that's basically what IVF can do for us. So ask them very specifically for all your official reports. You want to know about the sperm on the day of the egg retrieval. You want to know about the eggs on the day of the egg retrieval. Ask them, were there any physical characteristics that you saw in my eggs that would lead you to believe that this could possibly happen? Were they dark? Were they grainy? Did they have, they're called SER vacuoles. Was there something about the eggs that makes us think that this could be an egg quality issue? And then also ask, is there something about the sperm that makes us think this could be a sperm quality issue? And then ask about genetic screening that you've done. Have you done enough? Does it make sense to do a chromosome analysis for both of us? And then regroup. Talk about what you can do to support embryo health, embryo growth, embryo progression, looking at things like supplements, lifestyle medications that you are on or not on, and see if there's things that you can do to optimize your chances. And don't give up. I have some acupuncturists that I have my patients go to. I have my patients work on mindfulness. And then we work on, for example, living and being as healthy and living the best and having the best healthy. You guys, I've been doing this since 6 a.m. Not doing the show, but talking. So bear with me for a second. You know what I'm saying. I don't focus on patients with weight loss. That's not what I'm trying to say. I'm trying to say I want people to focus on being as healthy as possible. Whew, the words came out. Great job, Amy. Yay. Okay, so I'm going to go down here and see if there are any more questions. Someone is saying, thank you, John, that he will vote for me for fertility surgeon general. I think we need to create that. Someone's asking me what brand my lipstick is. So I have really generous patients, and they bring me things like lipstick. And I have a patient that just brings me lots of lipstick, and I would adore her even if she didn't bring me lipstick, but it's pretty cool that I get so many lipsticks, and I would have to ask her. So someone's asking me about prenatal and vitamins I should be taking every time I take letrozole or Clomid. I've just had one follicle. So as far as prenatals, Theranatal through Theralogics, you can use code TUSHY, TUSHY. They also have code Q10 as well. So those are the supplements that I would take. Janelle is saying hi. Hi, Janelle. So what supplements would you recommend for DOR patient, 33 years old, AMH of 0.03? So if your AMH is 0.03 at 33, I would rule out autoimmune issues. Ask your doctor about checking anti-adrenal, anti-ovarian, anti-thyroid antibodies. Ask them about Fragile X screening, chromosome analysis. Talk about whether naltrexone is something that they might want to consider for you. It is a novel way of dealing with what we call autoimmune, and I hate the word failure, premature ovarian failure, but Autoimmune primary ovarian insufficiency is another way that we talk about it. But in the literature, if you go to PubMed, you're going to find a lot more articles about autoimmune POF. So start reading about it. Bring the articles to your doctor and talk through what strategies they can use to help you. And ultimately, if you need more help, call me. Have your doctor call me, and I can tell them what kind of things I've done. And then the supplements could be things like NAD, CoQ10, and the prenatal with good vitamin D and fish oil. Someone's saying, Dr. Amy, I love you. Thank you, Emma. I love you too. What % of people need the ERA test? And are there signs that I might not be receptive without a failed transfer? So Emma, there really isn't. That's the thing. You can't see these genes inside the uterus. You have to remove cells and analyze them. I hope one day, and I know there's going to be a way eventually to non-invasively do the ERA test and just aspirate some fluid so you don't have to go through an entire cycle of medications, because that's freaking awful. Like, I feel horrible that I have to be like, oh, in 1 month we can get an answer and then you can transfer the next month. Like, that's just stupid. But unfortunately, that's like the best that we have. So to answer your question, no, there isn't a way that we can just tell if someone has receptivity issues or not. So Pav is asking, can endometriomas grow due to IVF stim? Could it rupture? I want to get as many retrievals in before another surgery. And the answer is yes. Endometriosis can certainly grow. They're hormonally receptive. They can grow and then they can shrink right after the egg retrieval. And they can, I've never had one rupture myself, but I'm sure that there is someone out there that's seen that. So my doctor said 99% of the Receptiva DX tests he does come back positive. And I would say, wow, he just has a lot of patients who have positives. I don't find that. I have not had 99% of my patients come back with positive. The positivity rate is a lot lower. I would say it's probably around 60 to 70%, which is pretty typical for patients who are having trouble conceiving. So I'm not surprised with it at all, but it's not 99%. So someone is asking, do you believe that HCG wash helps implantation? Do you give any HCG injections on the day of the transfer, day 3 or day 4? And the answer is no. I have tried HCG washes. I don't find them particularly helpful. I didn't notice that my pregnancy rate increased. Things are very trendy sometimes with IVF. Like, there's a trend and then it goes away and then it comes back and then it goes away and then it comes back again. And like now we're riding the HCG wash trend again. So it seems like it's coming back. There's a wave of it. And I can tell you that I've done so many HCG washes, and I can tell you that in my experience, it hasn't helped me and my patients, but maybe your doctor has a different way of doing it. So trust them and see if it's something that they recommend for you. I would say just try it and see. And if it feels right, do it. As far as HCG injections, progesterone does the same thing. I don't find that HCG injections are particularly helpful or useful. And my patients are already taking so many drugs, I don't necessarily think they need to add HCG. But there are places that use HCG, and it's another way of boosting your progesterone, and it doesn't hurt. This is from Soup Dumpling. What do you recommend for those not responsive to IVF meds? I always get only one follicle. I also have DOR, poor egg quality, age 37, unexplained. So it sounds like you have an explanation. It's poor egg quality. So let's figure out how we can support your egg quality. Look at supplements like CoQ10. Look at your lifestyle. Talk about taking NAD and discuss HGH with your doctor and see if DHEA is something for you. Make sure you've done enough genetic screening as well. And last but not least, just go for that one egg. If your AMH is really low, your potential number of eggs that you can grow, I love that. If your HCG is low and the potential number of eggs that you can grow is low, then go. Yeah, don't sweat it. Don't take, medications that are going to suppress you. Don't take $7,000 worth of medications to grow the one egg. Just work with what you have. Remember, less is more when you have less. Okay? It's all about quality, not quantity when you have less. This question's from Bon. I've completed many tests. My partner and I have had 3 chemical pregnancies and 1 miscarriage with no heartbeat at 6 weeks and 1 blighted ovum, 2 sacs. What is the issue? So it could be, obviously, there's something that's embryo-driven, whether it's related to how the embryo implants and attaches to the uterus, like inflammation in the uterus, or whether it's something genetic in the embryo. It's hard to know for sure unless you test those pregnancies. So I would just say, look at it all. Look at the uterus. Look at the genetics of the egg source and sperm source, and talk to your doctor about what have you ruled out. You can take my angel method or angel approach and just go through that very systematically, but depending on your age, if you've done IVF or not, I would say you might be a great candidate for doing IVF with PGTA and then doing the implantation testing that I always talk about before your transfer. So this is a great question about steroids to everyone for 4 days before the FET, and I say yes, I do that. As far as it's science-backed, there's a lot of literature on using steroids in IVF. As far as like whether the literature shows that it helps everybody, it doesn't seem to. but it's something that I think for some patients it might help, and it doesn't necessarily hurt unless you have side effects. Someone's asking me, what's my favorite trigger shot? Someone with no risk of OHSS, what dosage and which trigger do you use? I love HCG. I love a nice juicy dose of HCG, like 10,000 units for my patients if they're not at high risk of OHSS. And the reason is I think it gives us more mature eggs. And there's less risk of having a trigger shot failure if you use HCG. You guys look. I stole this cup from my husband. This is his favorite cup, and it matches my dress. Okay, so Wendy just asked a great question. Hi, Wendy. Is there such a thing as testing some embryos, excuse me, and not others for a higher chance of transfer options? So, of course, I do that all the time. Not all the time, maybe like 4 or 5 times a year. So I have patients that want to just transfer their very best embryo, and then we biopsy and freeze the rest so we know what we have in storage for us. Doable. You can also biopsy the embryo that you're going to transfer and then get the results later. That's kind of stressful. But sometimes people just want to know all the information, so you might as well biopsy it right before you transfer. So you have lots of options. So someone's asking, Amina is asking, what to do to prep my body for IVF? Best thing to do is look at your lifestyle. Are you as healthy as possible? Are you sleeping well? Bring in things that will reduce stress, raise the joy, right? Raise the joy, stomp out the ants, the always negative thoughts, stomp them out. Learn how to actively think and let those passive thoughts come out of your head so that you can, decrease your stress, decrease your cortisol levels. Find a meditation that you can go to like that as you're going through IVF. For example, I tell my patients, squeeze your buns. That's funny, right? When you're stressed, squeeze your buns. No, I do say that though. So when you're getting that blood draw and you're feeling like I'm kind of stressed and you can't focus, like you're just thinking about all the negative things as you're sitting there, if someone's telling you to squeeze your buns, you're going to laugh and you're going to be distracted, and then maybe the blood draw is not going to hurt so much. So this is from it looks like Betsy or Bestie, better than Bestie, Betsy. Okay, I have my retrieval today. Wait for the numbers. What can I do to prepare my body for the FET? Besides taking supplements, CoQ10 prenatal, iron and vitamin D, I'm about to start drinking bone broth, plus keeping my feet warm and doing acupuncture. You're doing everything. You're doing awesome. So I would just say perfection is impossible. And I don't define perfection as the things that a lot of people avoiding gluten. I don't really feel too excited about that for my patients, and I don't necessarily recommend it. There's certain situations where I'm like, yeah, you should avoid gluten if you can, but it doesn't have to be 100%. But I think the more logical things are talking to your doctor, do a post-IVF consult, have that scheduled, request all the official reports, and go through your embryo diamonds, right? Your diamonds. A lot of people just don't know what questions to ask. Go to embryodiamonds.com and you can learn more about what I'm talking about. There's the 8 things that you should know about your embryos, the day your embryo is frozen, the implantation rate per embryo, whether the embryo is abnormal, mosaic, get the official reports, which one's normal, will these embryos help you reach your dreams, and let's talk about sex. Just kidding. So the last S is actually the sperm on the day of the egg retrieval, but guys, you know me. I always just have to say, let's talk about sex. So my point is, it's important to know the information about your embryos before you move forward with a transfer. Far too often, I do these 2nd, 3rd, 4th, 5th, 6th, 7th opinion consults for people, and they're like, I just didn't know that I could know that. If I had known that I could know that, I would have asked the questions, and I wish I had known that before. So that's why I came up with these super cheesy mnemonics to help you guys remember these things. So I hope that one helps. Okay, what type of NAD do you recommend? Okay, Mrs. Happy in the Brine. NAD is made by one company called Chromadex, and they license it out to all these other companies. There's only one place that makes it, Chromadex. So the brand that I recommend to my patients is the brand that Chromadex, sells or makes, and that's True Niagen, TRUNIAGEN, and that's the one that I recommend. And you can get it from anywhere, because if it is truly NAD, they're getting it from the same source. Okay, dosage is around 150 milligrams. 300 is great if you can tolerate it. 300 can make you feel really jittery and really excitable, and you can tell that I'm on it. So this question is from Scorpna. Hi, Dr. Amy. I'm 39, had a miscarriage. It was trisomy. I recently had a full workup. Everything came out normal, but my, wait for it, AMH is 0.6. Okay, Scorpna, you're 39 years old. Talk to your doctor about doing IVF and go for it. Do all the things that I talk about as far as supporting your egg quality and keep moving forward. So Carlita is saying, can you take True Niagen during pregnancy? And my answer to that is maybe, but I tell my patients not to. How much vitamin D supplement do you recommend for pregnancy? It just depends on your vitamin D. My goal is, a level over 40. So, it depends on what your level is. 2,000 to 4,000 IUs per day can usually help. So this question from Scorpna is, my doctor is saying that my chances of conceiving naturally are between 2 and 4%, and my only option is IVF. I really wanted to do this naturally, but my doctor says she does think it will. Okay, Scorpna, your doctor is very negative. 2 to 4% at 39 with an AMH of 0.6. I mean, I get it. She's trying to scare the crap out of you, but my God, that sounds really mean. 2 to 4%. 2 to 4, yeah. The reality is at 39, the likelihood of conceiving each cycle or each ovulation is about 5%. So she's not like too far off, but like 2 to 4, I think is a little extreme. So my thought process for you is do what you feel comfortable with, but don't wait to do it if it's something that you would do at some point. So sometimes I have patients that say, well, I want to do everything else first. And then if that doesn't work, then I'll do IVF. And what I tell patients is no. Let's flip it around, because IVF doesn't work the first time and your IVF cycle may not work. So do IVF first, and then if that doesn't work, see what you learn, and then do everything else after that. Because people get pretty upset when they find out that their IVF cycle didn't work. And then if you had, let's say, done 6 months or 8 months or 9 months of treatment, you start to get filled with fertility regret, where you're just like, damn it, I wonder what would have happened if I had done IVF first. I wish, and I hear this all the time, I wish I didn't waste my time for 2 years doing IUIs when I could have just done IVF from the very beginning. Obviously, hindsight is 20/20, that saying. So be sure to talk to your doctor about your diagnosis, and it sounds like you know the diagnosis. Talk to them about how they would prepare you for IVF given the diagnosis, and then talk to them about the protocol they would use, why they're choosing that protocol, the side effects of the medications, and what to expect, and then go for it, okay? So you guys, this was super fun. Thank you for joining me today, and I'll be back here tomorrow to answer more of your questions with Dr. Shah. She is awesome. She's from Nova IVF. She's like down the street from me. She's super passionate about helping people just like I am. And if you guys want, hang out with me on Monday at my IVF class. eggwhisperschool.com is where you can find out the information. And I would love to see you guys there. And we'll talk more about the nitty gritty about IVF. I might sing to you. I might tell you way better jokes, or I might just be lying right now because I don't have way better jokes because I'm not that funny. But I hope you guys have a great night. And, send a letter to your senator and tell them that you want to make me the next Surgeon General. Okay, I'll talk to you guys later. Have a great night. Bye. Aw, someone asked me if I'm single. It's my husband. Bye, guys. Love you all.